So I was given a topic to speak on IOCT. So why IOCT? Because all over the world, everything has started based on technology. I'm a proponent of a good technique. I like to discuss techniques, but sitting in a hospital, the other person buys the technology. He says, I'm superior because I could afford this 1 crore, 5 crore machine. So let's see how it helps you or not, because we acquired this machine and this tool has been used by the refractive surgeons, cataract surgeons. So let's see, does it have anything to offer for the pediatric cataracts? Here we go. So what is the surgery as us now? What are we doing right now? According to technique here, there's no technology here, just a technique. You make 3-port incision, like Kalpana showed the surgery. I think I'll run it faster because that'll save me some time towards the end. You do the ACC, do a PCC, and then you do a vitrectomy, lens goes into the bag, and that's what you want. So how is OCT going to help us in any of these steps during the surgery? So let's debate on this and find out. At the end, I'll give you a conclusion where I find it's useful, and most of the places it's not very useful though. So it's a spectral domain OCT. It provides a high resolution in vivo images and have been used by the cataract surgeon as well as the refractive surgeons. Okay. Now the same technology has been got onto the microscope, and you can do the same thing per operative during the surgery, going from all the way from anterior cornea all the way going back to the retina. Okay. So corneal surgeries, it helps you the corneal, especially the DSAC, DLACs, you can actually see the images. If you're doing a smile patient, in case there's a lenticule not visible, put the patient on the OCT and you will be able to pick up the lamella very clearly. Okay, so where it's going to be useful, it's basically more of a tool right now, which is experimental, and you can use it for certain things. We're trying to put some data together. Maybe next time we meet, I'll be able to discuss that in more details. So you can actually see the lens. You can see the morphology of the cataract, different kind of congenital cataract morphologies, and you can actually have a typical pictures, which we are trying to find out, which can be seen on the OCT in these patients. Interlenticular changes I talked about, you can have a opacification of the anterior capsule or posterior capsule. So most of these capsule, which we feel is a thin single layer, is not so. When you do the OCT, you realize there are multiple layers sometimes, and some layers in the front of the capsules and some behind the capsules. So this is the other thing which we are looking into and we're able to find out. All these membranes are much clearer than what you can see on slit lamp or a naked eye, but the OCT is able to pick it up. You can work around the Burgess space. I'll show you some videos about the Burgess space, how you can actually define the Burgess space and find out how it's opening. And Mary Sessigan doing lots of work on the Burgess space. And of course, the wound construction can be seen. Okay, so this is video number 1 in which you can actually see the cataract. You can see the morphology up here. So this is not a typical zonular lamellar, because you can see there's a little more translucency in the periphery, and the central part is much denser. Whereas the lamellas normally have a consistency all around. You can have a central lamella, central nuclear also, but this was the different thing. So that you can pick up on that one. So along with the surgery when it's going on, you can pick up, and you see there's a membrane at the back, which is seen right now here, and that you can see the reflection on the back. So no big deal, you can see it otherwise also. So what happens when you break this membrane and try to see what's behind? You expect a hyaloid layer, but in this patient, it has multiple layers. It had 2-3 layers, and one was hyaloid layer, and one more layer was in between. We don't know what the layer is there for, but we could pick up just because the OCT was there with us. And I'll just run this video fast. The timer is not running there. Okay, so I have to look all the way up there. Okay, I got 4 minutes. Okay, fine. I don't want to listen to the bell. It's quite a harsh bell, so I'll finish before the bell rings. Okay. Okay, so see, I've got this plaque up, and the capsule was not open. And then once you open the capsule, we do the vitrectomy, you can see the opening. And now you can make out the layers quite clearly. So this was a patient in which the membrane at the back, and the posterior membrane was not one layer, it was multiple layers, and that we could pick up and manage it. So in cases of a patient where you don't want to do a vitrectomy and you leave the posterior lamellar layer intact, there's more chance of VO formation in these patients. But if you're doing a vitrectomy, it doesn't help you much, because in that case, whatever layer is at the back, you're going to eat it up anyway. And that's towards the end of the surgery, the lens goes into the bag, and you can actually ensure that both the flaps are in the front of the anterior capsule and posterior capsule at the back up here. All right, so let's skip to the next one. Okay. Here we go. So this one I've started after the anterior access has been done. I'm going to be making a nick at the posterior capsule. So when we started doing these surgeries, at that time, the dictum was that you make a nick on the posterior capsule and put a helon behind the posterior nick so that it goes and pushes the highlight back. So we stopped using that technique. What we do is now we put in a needle on the posterior capsule and scratch it through, and it breaks the posterior capsule without disturbing the hyaloid. So this was a technique which I used earlier. So I thought I'll just try to replicate that on the OCT. So if you notice here, once I put in the viscoelastic, the posterior capsule actually has come all the way up. It's all raised all the way up. Now it's actually looking like anterior capsule. Even worse than that, because it's much thinner and much anterior, and the posterior part is all full of viscoelastic. And we did a rexis in this one, and I realized that rexis was not as easy to perform once I had filled up the entire Burgess space. So if you want to do this technique, please ensure that you don't put too much of viscoelastic, because I just realized the viscoelastic was too much and the anterior posterior capsule was coming almost at the level of the anterior capsule. It was getting so pushed up. So once this rexis was done, you went ahead and did the surgery. So this was a thing which was in my mind for quite many years, that which is a better technique. So I can say that if you want to open the Burgess space, please don't overfill it, underfill it, and you can get away, or you avoid going there at all totally. Give a nick and do a rexis forceps with, pick up the rexis forceps and do it. I got 2 minutes, 10 seconds gone. Okay. All right, so when the surgery is over, you can make out the lens again in position and everything looks good here. Okay, now, okay, one more thing in this patient which I wanted to talk about. Okay, now what you see here, now this was the other eye of the same patient. It's in the same video though. So first I did this, I'm doing the second eye which I showed you, making a Burgess space up. Now this was the eye which I've done 3 days back, and you can pick up some changes on the anterior capsule. So if you pick up this was basically a reaction kind of thing which was there. So we gave an injection in that eye also, which was not visible to the naked eye, and the child was not showing. So once you have OCT, you can just switch over to the other side with a dilated pupil. And if you find this kind of thing, we gave an injection immediately there on the table, and the next day it all cleared up. So it can actually tell you if the VO formation has started that as soon. It's not possible to have it within 24, 48 hours. So this was actually a reaction which settled down. So that was another tool which you can use to pick up in these patients. So that's why I wanted to show this. And that's the last one, and there are different unique scenarios. So that's a plaque on the back. I've already removed the anterior capsule. That's a plaque in the posterior capsule, all the way big. So we give a nick and try to go behind it. And this was being cut by you can't do a rexis there. So I put in a MVR cut right in the middle. And then because there's a membrane at the back, I want to cut it all the way. You can put some visco behind it, and then you can actually cut it. So you can, grazing the thickness of the membrane on the OCT, you can either use a blade, or you can use a rexis forceps, or you can just peel it off. So that actually gives you an idea. So this was case number 2, in which again there's a membrane in the back, and we made an opening and pushed it, put an helon behind it. So you can see it's bulging up there, and we could do it, the rexis in this one. And since it was a small bulge, we could just localize in the central 3.5, we could actually do the rexis. And you see in these patients, when you're doing the rexis, it's getting stretched all the way out, which was not visible to the naked eye otherwise, and you can see it on the AIOCT if you have it. And then anterior vitrectomy, once it's done, the flaps fall back, and the entire posterior capsule again becomes, the curvature is maintained. Okay. Okay, now this was one of the patients in which both the capsular fuse, and on the OCT we could find that both the capsular fuse anterior posteriors, we were able to put the lens in the sulcus with a 3-piece. 30 seconds more, I think this is almost over. Now that's a patient with a persistent fetal vasculature, and there's a membrane with a vascularity there, which was very well picked up on this. And
just conclude, sir. Time is over.
No, I'm just done. All right, so here also you can see the multiple modality. You can see the thickness of the thing at the back, and once you cut it, so it actually gives you the thickness, a real-time thickness OCT, and tells you that you can actually use whatever technique you want. You can use a cutter, or you can use a diathermy in this patient in case you have a blood vessels on the top, and you can get away. And if it's a softer one, you can just aspirate it, or you can polish it off with your biomanual cannula itself. Right. Thank you. With that, I'll close the speech, and I'm open for any discussions or questions.
Yeah.
Thank you. Thank you.